The content of this podcast is for informational purposes only and should not be considered medical advice. Always consult with a qualified healthcare professional for any health concerns. Take care of yourself out there.
Welcome to Unraveling. This is a podcast that sees the world through the lens of mental health. I'm Mary Wilson, a journalist.
And I'm Kurt White, a social worker and psychotherapist. And so, Mary, in our last episode, we talked a bit about the hard issue of suicide, didn't we?
Yeah, I spoke with Dr. Conrad, who shed a light on suicide, especially among youth, and contagion, how social media plays a role. And this episode, we're going to talk about maybe an even less understood topic, but very serious, and that's non-suicidal self-injury, which can often maybe be confused with suicidal behaviors.
Yeah, I think it's something people may not know a lot about, especially in adults, which is where we're going to focus on today.
Yeah, personally, I remember hearing about this among my peers in high school, and since then, I haven't really heard about it again.
Yeah, and I think you're not alone in that. I think I was a bit aware that there were folks in college that maybe struggled with that, and later when I worked in college mental health, that was an issue for a lot of folks that maybe had started some sort of non-suicidal self-injury at a younger age, but it had sort of continued into adulthood. But it's actually perhaps more common than maybe a lot of people know, and maybe is associated with many different diagnoses, or maybe no diagnosis, which I think is a really interesting thing and is something that hasn't been studied as much in the literature as maybe it should be.
And that's why we really wanted to speak with someone who researches this, and that is Dr. Stephanie Steele.
Yes, Dr. Steele was introduced to me by a past guest friend of the show, Dr. Namdi Powell. They're both professors in the psychology department at Smith College. Specifically, Dr. Stephanie Jarvi Steele is an assistant professor there and directs the Behavioral Assessment of Self-Injury Lab, or BASIL, which aims to further elucidate risk factors for self-injurious thoughts and behavior. She teaches there about a variety of topics in abnormal psychology, personality disorder research, and a seminar on high-risk behaviors and psychological disorders. She's also a clinician licensed as a clinical psychologist as well as a researcher, and has published extensively on this topic for more than a decade.
Wow, very accomplished resume there. Let's listen in.
Dr. Steele, welcome to Unraveling.
Thank you for having me.
Absolutely. So today we're going to talk about something that isn't actually talked about a lot, but might be more common than people realize, which is non-suicidal self-injury. Before we really dive into it, what first got you interested in this topic at such a young age in your professional life?
I went to Smith College as an undergraduate, and I was at health services, for some routine check-in. I was sick with the flu or the cold or this, that, or the other thing. And I was sitting looking at a big wall of pamphlets about every problem any, college student could ever had. Medical issues, about sexual health, about gender identity, about sexual orientation, about you name it, vaccinations, whatever. And then there's a whole mental health section as well about, eating disorders and suicide and about depression, anxiety, and anything that up there. And nothing up there about self-injury specifically. And yet this was a problem on the Smith campus, at least that students were very aware of. And there were sort of these pockets. Smith is a very small liberal arts college. You live on campus in houses, not dorms. And so there's this really homey feel to it. And people, word spreads quickly. And so there were certainly, houses on campus and groups of students, groups of friends, if you will, where self-injury was sort of this identifying feature or factor that felt very prevalent and important and central to who they were. And that was happening. And that was a real thing that students were all very aware of. And yet we were not talking about this from a wellness, mental health level at all on campus. So the absence of the pamphlet was striking to me. I went to a psychology professor and asked if I could create a pamphlet. And as sort of a project to put into health services, I'd gather all this information and create something that could go in there. The director at the time of the health center said, absolutely not. We cannot have information about this because it will create this contagion effect. We will give people the tools and ideas essentially to engage in these behaviors. No. And so that I don't usually respond to being told no well. So I said, okay, well, here's my next proposal. And as a budding scientist, I said, well, what if I then write a paper, and look into this idea of, is there anything behind this idea of, I didn't know either, but has anybody asked this question? Is this a behavior that has this socially contagious effect? And so at the time, the research was quite minimal, but there was enough out there. And so I did a literature review and wrote a paper on self-injury and contagion to then present back to the health center to say, here's what I found on the topic.
Did they let you make the pamphlet?
At the time, they did not. And then about a year later, after I'd graduated, I was invited I published the paper. Yeah. It was called a special studies at Smith. It was sort of like a mini thesis is a way to think about that. And then I published the paper with my advisor after the fact. And the director of the center then asked, hey, do you still want to create that pamphlet? I should have done it. I did not. But by that time, things had shifted and changed, as you said. Things were happening pretty rapidly. And there were, groups on campus where I think, social workers and psychologists within the health center got more involved. They were doing more sort of primary prevention and psychoeducation on campus. And it had just become more of a conversation without me doing or saying anything about it. But, yeah, so it was I think that conversation though was really interesting in thinking about the dynamics of the level of concern that was initially brought up, and then years later that this was something that people were talking about pretty freely on campus, between the folks in the academic role, the administration, the students, et cetera, and the floodgates had kind of opened at that point.
Yeah, that's really interesting. Maybe you'd have some thoughts about why it's so hard to talk about. Part of the challenge with it, isn't it, is that there is probably maybe a conflation of the suicidal preparation or behavior or intention and a non-suicidal self-injury. Can you sort of walk us through how those things are alike and not alike?
Sure. The broad term that we tend to use in research and clinical settings to cover both suicidal and non-suicidal self-injury is a mouthful, is self-injurious thoughts and behaviors. And within that umbrella term, then you have the non-suicidal self-injury side and then the suicidal side. And the main difference between those two categories is intent. With non-suicidal self-injury, we think of the function or purpose of these types of behaviors as typically having something to do with emotion regulation, regulating affect in some kind of way to reduce it. I don't want to feel the intensity of the feeling that I'm feeling. In some cases, it's to feel something. I feel nothing. I feel numb, and I want to feel something, even if it's pain. And then there's also some social functions and factors like engaging in non-suicidal self-injury to communicate an interpersonal need, to get a need met that I don't have another way of communicating I need. And also another social factor can be engaging in self-injury to escape an interpersonal demand. So the common example that comes to mind is, for a younger adolescent or child, being told to do homework, getting really emotionally dysregulated, running away from the situation, engaging in self-injury, and then sort of the focus shifts from the focus on the homework, we asked you to do this, to now the larger problem or...
Yeah, they changed the subject very effectively in some ways, right? Yeah.
On the suicidal side of that umbrella spectrum, you have suicidal ideation, which is thoughts of suicide. Those can be very passive thoughts, like thinking about death or dying, but not having any sort of active thinking about hurting oneself. Then we also think about suicide intention. So how strong does the person intend to carry out those actions or plans?
You mean a person might be having some suicidal thoughts, but engaging in a kind of self-injury that is the intention of helping regulate emotion rather than moving one toward death and dying, for example.
Yes. And I think that sometimes people don't know exactly what their intention is when they're engaging in a behavior. So there can be more gray area there. And on the flip side, though, I should also say that oftentimes for folks, it's very clear what method they're using and what function it's serving.
Now, for people who are maybe not clinicians or who don't have personal experience with this, it might seem quite counterintuitive, actually, that self-injury could have an emotion-regulating function. How does that work?
Yeah, I think the important thing to understand is that this tends to be short-term relief. Let's say where they're experiencing really high-intensity anxiety. They don't like that feeling. It's distressing. And so an episode of self-injury either distracts from the existing emotion because of the pain potentially associated with the self-injury. Sometimes people don't experience pain when they self-injure, and they actually experience relief. And, sort of a physical and emotional relief. And sometimes there is this short-term benefit of the focus is now on the self-injurious act and is not on the emotion. The downside is that either that emotion comes back relatively quickly, and or it comes back even stronger, right? And so we sometimes see this snowball effect where people will describe, I engaged in self-injury, and, my anxiety went down momentarily, but then my anxiety went back up. And now I also was distressed by the fact that I self-injured. So another emotion may enter the scene.
Now, I think probably many people will have heard or thought about self-injurious behaviors of younger people, adolescents, or sometimes even sort of the tween kind of group and the rest. But your research is really on adults. But I'm kind of interested in the intersection of things. Who are the adults that do this? And, if you could tell us about that. Are they folks that started when they were young, or does it sort of a problem or an issue that carries on for them or develops in adulthood?
Yeah, it's not as common for self-injury to have adult onset. It can certainly, I can think of a couple cases perhaps, but typically when we see adults struggling with self-injury, this oftentimes is a behavior that started in oftentimes adolescence or in the preteen kind of age and stage of life, sometimes earlier, even in childhood. What tends to happen is that methods of self-injury often change over time. So as a child, you may have access to less things. Teenagers have more access to more things. Adults typically have access to what they, whatever they need or want to use. But the reason for the function behind the self-injury often is pretty consistent over time.
Do people generally consider it a problem for themselves?
I think it depends. People seeking treatment typically are people who do see it as a problem or someone in their life does. And so I think oftentimes our sense of bias by the fact that we as clinicians more often see the people who are seeking help.
Yeah.
And in research as well, right? You're oftentimes recruiting participants with this or that background, and you have these eligibility criteria, and those are people who are sort of in remission or recovery from a problem or who want to be. However, a lot of our online research and with just online groups and social media in general suggests that there are other folks and groups out there of people who do not see this as a problem, do not want to stop, do not necessarily want help, and are really protective over being able to use this behavior as much as they wish.
That's interesting. It's a little bit like when you study substance use disorders, actually, right? I mean, there's the sort of population seeking help for that, but then there's the sort of underneath that a large group of people that might have a diagnosable problem, for example, but are not actually seeing as a problem or looking for help.
Right. And very similar as well to the eating disorder community in terms of the patients that you may see who are seeking treatment for something like anorexia or bulimia or binge eating disorder. In treatment and research can look really different than the online communities of folks who are really actively engaging in disordered eating and are really not looking to change those behaviors. But I would say that these are often fluctuating. And so there may be a period of time where an individual says, I don't want any help with this.
Right.
This is what I'm doing. It is what it is. And then another period in time, things have shifted entirely and they're very much ready for help, or they are motivated in a different way, or they're seeking a different outcome or what have you. So I think that fluctuates quite a bit for people over time.
What mental health diagnoses is self-injury most associated with?
But we see very high rates, 90% and above, of individuals diagnosed with borderline personality disorder, which is a category of disorders that falls under the personality disorder category in the Diagnostic and Statistical Manual of Mental Disorders.
Not without its own controversy, that diagnosis, right? It's
Right.
because it's often associated with a lot of trauma experienced sometimes in earlier life and childhood.
Absolutely.
Yeah.
In terms of in taking this more DSM perspective, self-injury is listed as a criterion for borderline personality disorder. We typically ask about and assess for non-suicidal self-injury when asking about symptoms of depression. And then you also see self-injury listed in the DSM under the diagnosis for autism spectrum disorder.
Mm-hmm.
Those are the three places in the DSM, in our official diagnostic system, where those where you would actually see self-injury listed as part of the diagnostic criteria. But we see self-injury occur transdiagnostically across disorders. So you may see it in an anxiety disorder. You most certainly see it in folks with trauma and post-traumatic stress disorder, PTSD. And you also will see this in the absence of any disorder at all.
I think, if you look at the behavior on a kind of human level, it often feels really quite extreme, I think. I wouldn't think that sort of actually injuring oneself would be a way to move toward something like symptom relief or, a sort of a social consequence that would be favorable in the way that you've mentioned it. I mean, that there would be a kind of an instinct or an urge to not do that, right? To sort of like, we don't like to see that. You faint at the sight of blood or something. Maybe there's even biological mechanisms that would move us away from that. But I think, as you've mentioned, it does serve certain functions, and folks who are doing that might look at it in a very different way. How do people who are engaged in these behaviors see and describe what they're doing?
That's something that in treatment sometimes that we talk with patients about in dealing with self-injury and treating self-injury is that all behavior makes sense in context.
Mm-hmm.
And so that's a message, not necessarily that patients are sending us as clinicians, but that we are often trying to communicate to patients to be validating and empathetic. Like we understand that this is working, because if it didn't work, then you wouldn't be doing it.
Mm-hmm.
Maybe you did it once and it did not serve the function it needed to serve. It was painful, or it was problematic in this way or that way. You didn't get what you wanted out of this, and so you're not going to do it again.
Mm-hmm.
And for some people, that is what happens. But in other cases, more often than not, self-injury tends to be repetitive. People engage in typically do not say, I did this one time. The more typical response is that I did it repetitively for this period of time, or, in this sort of episode of life. And so I think that in the absence of more adaptive coping skills, self-injury, similar to disordered eating, similar to substance abuse, similar to engaging in other risky behaviors, even things like risky sexual behavior, risky spending practices, oftentimes we know consciously this is not my best option, or this is not good for me, or this is not what I want to be doing or should be doing. And yet I am finding myself doing it over and over again because I don't have a better option. I don't have the skills or knowledge or ability to deal with this in a different way.
Mm-hmm. Mm-hmm. That's really interesting. And some of your research is around the concept of self-disgust and the association of that. And I'm curious about that. What is self-disgust, and how are you finding that as related or not related to these kinds of behaviors?
Yeah. Self-disgust is something that we're interested in as an emotion that may be a more proximal predictor, meaning it's happening just before someone actually engages in self-injury. So much of our research in suicide and in self-injury has uncovered distal risk factors. So things that are in the past and or things that I cannot change. So these are things that put X person at higher risk for X behavior, but it's something like, socioeconomic status or race or gender or a diagnosis or something like this. But what the field has been moving to do now for, I would say, a decade, if not more, is trying to find what is happening just before the behavior occurs. And so one question is, what emotions are most often associated with an actual episode of self-injury occurring? And so self-disgust is something that we're curious about in and this is sort of exploratory for me in my lab, of understanding, can self-disgust predict self-injury? In some way, is this a helpful emotion for us to understand in the way that anger and anxiety, sadness are some of the, I guess, the bigger emotions that have been studied. But self-disgust has kind of been in the background there. And yet oftentimes lots of folks will talk about self-hatred, punishing oneself. This is another sort of area of functions of self-injury where people are engaging in this out of those, out of a desire to punish, to self-punish, to say, I deserve this in some way. And so, so far in a college student sample, and now we're currently collecting data with patients who are seeking treatment, self-disgust is looking like a relatively strong predictor of history of self-injury. And so that's giving us a little bit more information about thinking about the role of self-disgust in self-injury, and more importantly, this is not what we're studying exactly, but how that may inform treatment. Could clinicians do something with that information? And could self-disgust be an emotion that's more integrated into emotion regulation, skill building, or something like this? Because it's not the typical emotion, I think, that we often go to first. We think more about sadness, anger, anxiety, guilt, shame, sort of the core emotions that we talk about more commonly, at least in more cognitive behavioral interventions.
Right. And disgust is sometimes, if I'm remembering it right, not self-disgust, but disgust in general is sometimes thought of as something that probably developed evolutionarily to keep us away from very dangerous things in a way, isn't it? Like, it's we're meant to have an aversion to rotting corpses, for example. It's actually very dangerous. I've heard that from evolutionary biologists. But so it's interesting in a way that self-disgust exists at all, right? I mean, you could it's almost an inherently kind of problematic feeling that one might have. But actually, when you think about it, maybe it's not as uncommon as all that, but not something that really gets talked about quite a lot. And it's really interesting.
Right.
And it's a very, maybe it's an obvious thing to say, but there's a real physicality to it, I guess. Like it more than many other symptoms, it definitely has something to do with the body, right? It's a really very embodied feeling.
Mm-hmm. There are patients I've treated in research that I'm sort of loosely aware of where the method chosen to engage in self-injury, but also the location on the body sometimes is very significant for people. And so, for example, again, with tends to come up again with patients with eating disorders who are particularly distressed by a certain part of their body, whether it's shape, size, et cetera, where they may be engaging in self-injury to damage or hurt that particular part of the body. And that comes up in trauma and post-traumatic stress disorder work as well. Some individuals, this seems to be not particularly relevant, and they're choosing, the location on the body sort of based on what they can physically reach, what can be oftentimes concealed and hidden away, things like this. And so in those cases, maybe doesn't have some sort of deeper meaning or significance, but for other patients, it certainly does. And it sort of leads into the stigma related to this in a way of like it's not an easy thing necessarily for people to talk about. Although you have mentioned certain motivations in which maybe it would be important that it be known, right? Actually, it's maybe a communication in a certain sense, but oftentimes it is concealed, and I wonder if you have thoughts about why that is. For a couple of reasons. One is not sort of knowing how people will respond, that they will sort of startle or scare the person, that this is something that they are ashamed of, that they believe they should hide, that this is something they're going to keep very private for any number of reasons. Fear of hospitalization, right? Being misunderstood, and particularly a clinician misunderstanding an incident of self-injury actually being suicidal in nature. And so saying, jumping to conclusions and saying, we must hospitalize you. This means this, that, or the other thing. And when, that's not what the person was intending to communicate at all. And oftentimes people will say, in the beginning, I didn't think that this was something that I needed to conceal, but I had this really bad experience where I told someone, a friend, a teacher, a parent, a clinician, and the reaction was not what I was looking for, brought up all these feelings of shame and guilt, or I was hospitalized, or I was misunderstood in this way. And so I'm not going to ever do that again. And so oftentimes people are very relieved when they have a conversation with someone who's educated on the topic, and it's just a relief to say, wow, you're bringing this up, and you're not cowering away, you're not trying to hospitalize me, you're not saying, oh my gosh, what, you're not coming at this and you're not startled, you're just sitting with me, you're able to sit and tolerate the conversation, and you seem somewhat educated on what this means and what it's all about. And it creates this, sometimes the first time someone's ever really been able to talk about it in a way where they're not mincing their words or being really careful about what they say, but can be really honest about it. And that can be, I think, a huge barrier to break down in therapy to allow people to then do the work if they're looking to change or manage the behavior differently.
Yeah. And are you concerned, like in suicide and suicide prevention, about the possibility of a contagion effect here also? And if people talk about it directly like that, some people might worry.
Yeah, people do worry. Research shows across the board for suicide and self-injury that asking people about suicidality, asking people about self-injury does not increase either behavior. It does not increase people's urges. It does not increase thoughts of these types of issues. And this is in a clinical setting. If you're talking, in a clinical interview or a diagnostic interview, in a therapy session, and also in research. So these are two very separate fields. We've looked at this in the suicide literature, even longer than we have with self-injury, but other research has been done on self-injury specifically as well, that these are safe topics to talk about when they are talked about well. So providing psychoeducation, talking about, primary prevention types of measures that, a school or a university or a college may roll out just to inform people about these behaviors, does not create what we call an iatrogenic effect. We are not creating these behaviors in people because we brought it up or talked about it or what have you.
Yeah, yeah. And, I think when I think about these kinds of behaviors and the arc of my career and sort of observing how people think and talk about it, it's been a pretty profound shift in the, I first started my graduate training in 2001. So we're sort of coming on 25 years of that. That at that time, I think we didn't even have a good language for it. Yeah. People often use the term self-mutilation, which was a little bit intense. And I think I saw a lot of clinicians that really didn't draw any distinction between this and a suicidal kind of behavior. That idea was out there. And I think a lot of people were worried that this was a thing that was increasing drastically, right? But I remember I heard some researchers say, no, we just weren't asking about it, right? People have been doing this all along. And even went back and looked at like hospital notes and records from decades before, and it was mentioned, and the clinicians would just kind of ignore it, actually. So they're sort of like, it's a thing, it's a kind of thing that has existed, but people haven't been looking for it. Is that your perspective, that we're kind of like, even as therapists and researchers, trying to understand and adapt to this reality that maybe we haven't been tuned into?
I think so. I think I sort of have thought about it as long as I've been thinking about, being a psychologist and being in this field from a research perspective, as a clinician, what have you. These behaviors are happening across age groups, across gender, race, as we talked about. If you were going to be a clinician, you will see these behaviors in some capacity, even if you're not an expert on this, you don't want to focus on it, what have you, but it will come up. And so it just seems like one of these things that should absolutely be a core part of training in any field of psychology, social work, mental health counseling, what have you, because we'll all have to face it in some way, even if it's to refer out and to know what to do or how to connect people with the right services. No research has ever shown that there's been some big spike in self-injurious behavior, but more so that we started asking about it, documenting it, researching it in a more systematic way, and talking about it in more transparently, more directly, and that's opened up channels of communication with patients in a really different way.
And so these two things, suicide and self-injury, they are related in some complicated ways, though, aren't they?
Yeah. These things do overlap. And so people may experience both at the same time. An individual may be thinking about suicide, feeling suicidal, and engaging in self-injury sort of in the same time period of life. Or they may be very separate. They engaged in self-injury for this period, and then they felt suicidal at another period of time in life. What we do know from research is that non-suicidal self-injury is a risk factor for suicide. And so it's not the case that all people or even most people engage in self-injury and go on to experience suicidality, or that they will make a suicide attempt or complete suicide. But this is an identified and important risk factor, typically understood because it lowers inhibition for suicide. And in research speak, we talk about that as the acquired capability for engaging in a suicidal act.
You've mentioned about proximal, sorts of thoughts and feelings and indicators of a behavior. This is a thing that we're interested in also in suicide research, I think, right? Because you can identify sort of statistical risk factors for things like self-injury maybe, or suicide. Definitely, I know more about that myself. But it's very hard to know, like, even if someone is at high risk, statistically, on what day and in what moment would they be most at risk, and what would be going on for them. We know comparatively much little about that. So I'm really very interested in this proximal risk factors. Is that why that's important to you also?
Yeah, and what we know, unfortunately, about clinicians, we all are not as good of predictors as we think we are of which of our patients will go on to engage in self-injury or particularly suicide. And we're actually pretty bad at that. So we often use these categories of this is a lower risk patient or moderate risk or high risk. And sometimes our highest risk patients will never make a suicide attempt or a particularly lethal one. And our lowest risk patients are the ones who have never engaged in any kind of suicidality. They have really passive thoughts, and they may be the patient that goes on to attempt or complete suicide. But if patients say, I'm not going to engage in this behavior again, or they say, I am going to engage in this behavior again, they're usually right. They're better at those predictions than clinicians are.
Yeah, that's so interesting. I think, if we think about somebody that might be struggling with this kind of behavior, or maybe someone that knows someone that is and doesn't know what to do, what would you want to say to them about help that might be available, or how to think about this, or what to do?
I think it depends who the person is and what, relationship you have with the individual that you're concerned about. That the hat you can wear in those situations varies quite a bit if we're talking about a parent versus a teacher versus a friend or what have you. But I think the direct and transparent communication, asking direct questions, not talking around the subject, but saying things like, have you had thoughts of hurting yourself? Have you hurt yourself? I noticed this scratch or cut or burn on your arm, but in a very gentle, validating, empathetic, supportive tone, and communicating this through body language as well, making eye contact, leaning in, being really like physically present with the person, without, of course, being overbearing, but, sort of being able to communicate verbally and non-verbally that you're able to sit there and ask the questions and hear the responses, regardless of what they're going to be, and that this is not a scary topic. However, it is a serious topic, and that it is important to seek help, and that there are resources out there. There is help available, and we do have treatments that are helpful, and that this is not something that only, this individual is doing, that this signifies that they are, so bad or so crazy or so enter other stigmatizing language there that sometimes people think of, this happens less now with social media, but historically people would think, I'm probably the only person that's ever done something like this. And there's this really shame, it's shaming and it's isolating. And I think that happens less now, especially with younger people, because they can Google these things or look this stuff up on social media. And so they get a sense of the fact that not just self-injury, but other behaviors like this are happening on a much grander scale, for better or for worse. There are pros to that and big cons to that as well, and everything in between.
And one thing that's really impressed me in talking to you today is that this has been really a long-term project of yours to really understand these behaviors much better in the field. And from your perspective as a researcher, are you optimistic about what we're learning and where that's going, and about where that is going to go into the future?
Yeah. I do. I don't mean that to make something light of something that's not a light topic, but I do feel optimistic because I think that the cool thing about where the research is going generally is so enhanced in many ways by technology. There are so many downsides to the role of social media and how people are communicating about self-injury and suicide and this, that, and the other thing. But some other parts of technology have been so helpful and has really pushed the field forward in this way of understanding what is happening, again, in the moment, right? In this sort of like real-time assessment. And there's a sort of whole category of methodology and research called ecological momentary assessment. And what that essentially means is using things like our iPhones, our smartphones, what have you, smartwatches, all kinds of different, devices that you can have where you're getting real-time data. So you ping someone and say, how are you feeling? Or do you have this thought? Or do you have this urge? You're asking questions in real time. And researchers are now able to collect that data rather than you come into the lab and you say, hey, a week ago on Wednesday, did you have a thought about self-injury? Yes. How strong was the urge? And now I'm reading an urge I had 7 days later, which of course has all this issue with accuracy and bias and what have you. So I think our questions we're able to ask, we're able to get answers in real time. We're trying to understand and uncover, again, those proximal risk factors for self-injury. What happens just before an individual engages in self-injury? And technology has had a huge role in allowing us to start answering
what are their
those
thoughts
questions.
and feelings and all of that is what you mean.
Absolutely.
Yeah, very good. Well, thank you so much, Dr. Steele, for joining us today.
Thank you very
Unraveling.
much.
Absolutely. So thank you again to Dr. Steele for that wonderful and really educational, informative interview. I learned a lot, even having been in the field a long time. And joining me again is Mary. Hi, Mary.
Hi. Yeah, I learned a lot too, especially just how important our reactions are if we were to discover a loved one was doing this. It's so scary and you maybe don't know what to say, but reacting possibly in the wrong way can lead to further consequences.
Yeah, I think it's an interesting thing that there's a possibility of underreacting, right? As she describes, right, not even having accurate information about that this is something that maybe someone is not alone in if it's something that they're struggling with, and overreacting, in a way of sort of catastrophizing or assuming that it's suicidal sort of intent rather than sort of asking about it or being curious in a more neutral, non-judgmental, but caring way.
Yeah. And sort of a parallel to how you might react to someone who is feeling suicidal by just asking them those direct questions. That can be tough to do.
It sure can. And I think there might be many different kinds of meanings that a person might make of it in their own life. It might be something that they want help with. And if that's true, we want people to know that there is treatment available that is helpful for these sorts of problems. And it might be that someone might have that and not want help right now, too. And that's okay,
And we want people to find the help and the resources that they may need. And Dr. Steele passed along some of those to us.
Absolutely. She mentioned specifically some resources. The National Alliance on Mental Illness has some online resources. And at the Cornell Self-Injury and Recovery Resources Program has some excellent work. There's also crisis lines available if you are in trouble or immediately struggling with self-harm urges or, of course, suicidal thoughts. We'll also put some links to a paper and some work that she's done on this topic if people want to read more of her work.
Yeah, such important work she's doing, and I'm so glad that we got to speak with her.
Me too. I hope her research continues to go well for many years into the future because there's so much still to learn about this.
And we'll see you next time.
Unraveling is brought to you by Brattleboro Retreat. Our producers at Charts and Leisure are Andrew Atkin, Hans Buteau, and Jason Oberholzer.
And you can find us on social media by searching Brattleboro Retreat. Brattleboro Retreat is committed to exploring diverse perspectives on mental health. While we invite hosts and guests to share their insights, the views expressed are their own and do not necessarily reflect the policies or positions of the hospital or its staff.